Welcome to Diet Doctor News on YouTube. I'm Dr. Brett Scher, Medical Director at DietDoctor.com. Today we've got a little special news section. It's going to be an interview with Deirdre Tobias. Now, Deirdre has a doctorate in nutrition and epidemiology, and she's an assistant professor in the Department of Nutrition at Harvard Medical School and the Harvard School of Public Health, and she's the academic editor of American Journal of Clinical Nutrition. So she knows her stuff when it comes to nutritional science and specifically nutritional epidemiology. Now, she took it upon herself to do an analysis of the Women's Health Study database to look at the question of, does elevated LDL with quote-unquote normal HDL and triglycerides still correlate with increased all-cause mortality? And so we're going to talk about that study that she did. And, you know, we don't go into necessarily all the details, but there are certain things like, you know, there was one blood test at the beginning of the test that wasn't followed up for the rest of it. Okay, so that's a weakness of the study. You know, they didn't necessarily screen for any genetic conditions. Okay, that's a weakness of the study. But you can't, I guess one of the biggest points that she makes and that we try to make during this interview is that you can't control for everything in these analyses. They're not perfect analyses, and they're meant to be one piece of the timeline, one piece of the evidence to point in one direction or another. So the question is that's sort of hard to understand and hard to answer is this what we should be looking at, right? Do we need specific studies to answer the question? Do these interim studies add much, or do they help with the individual person? And they're hard questions to answer, right? There's not an automatic yes or no. Some people are going to come up with their automatic yes or no conclusions, and that's okay. That happens. But I think that the discussion is even more interesting. So we're not going to solve the world's problems in this interview. We're not going to come to a definitive conclusion in this interview. But I think the discussion is still important in the analysis just to kind of help us further refine how we see nutritional science. And I think this is going to be an ongoing discussion forever, for the rest of our lives, as long as we're trying to figure out the connection between nutrition and health. We are going to have to deal with imperfect science. We're going to have to deal with science that we don't always know what to do with, and trying to figure out whether we include that as part of our analysis or not, and how much weight do we give it. That's going to be a battle forever, and that's a battle I'm signed up for. I want to try and help along this path, and I'm not always going to be right. I'm not always going to have the most thoughtful answer, but I'm certainly going to try. And so is Deirdre. So is Deirdre Tobias. She clearly is in, and she has a great mind, the way she thinks about things in her perspective. So anyway, that's a long rambling intro. So let's get into the topic for this segment of DD News to talk about Deirdre Tobias's analysis of the Women's Health Study, analyzing LDL, HDL, and triglycerides. All right, well, Deirdre, thanks so much for joining me today.
Thank you so much for having me on.
Yeah, so I wanted to talk specifically about this little project you did, or maybe not so little project. I'm sure this took a lot of time to dig into the database for the Women's Health Study and try to break it down. Does LDL correlate with increased risk of all-cause mortality despite the HDL and triglyceride ratio? So this was something you posted on social media, on Twitter. And actually, quick funny story before I even ask you about it. I was talking to a friend of mine, a colleague at Diet Doctor, who's not on Twitter, has nothing to do with social media, so his mental health is much better than most of ours. But I was explaining what you did, and his first question was, well, who is this? Like, does she have the chops? That was his terms. Does she have the chops to really go through and do this? And we looked you up, and we're like, oh, okay, assistant professor in the Department of Nutrition at Harvard School of Public Health. She got a PhD in nutrition epidemiology. She's the academic. Okay, she's got the chops to do this. But more importantly, what motivated you to do this? Why did you think you needed to step in and do this analysis to share with everybody?
So that's a great question. There was this, I guess, crowdsourcing RFA of activity on Twitter one day, and a colleague sent me the link saying, oh, you'd be perfect to do this. Perfect, I think probably in the sense knowing I had access to very similar data that could address that question, which I did. So I jumped up at the opportunity. There was a little bit of a funding incentive initially, which inevitably I turned down. So full disclosure, this was done completely for no funding whatsoever to me. And the impetus for doing it was really just, it seemed like the more I dug around, the debate was very hot over this question. And, knowing the data were there and existent, and I had conducted similar analyses in this data set before, I knew it would be somewhat straightforward to tackle, to, kind of offer this debate that seemed very hot on this one question.
Yeah, so the hot debate is, does elevated LDL impart a negative risk factor whether or not the HDL and triglycerides are indicative of good metabolic health, basically? Is that sort of how you see the question, basically?
Yeah, and the causality, or how bad is bad cholesterol, that has been a debate, I would say, for a while now. So it was surprising to me that it was reemerging so vigorously, given that it actually isn't a new hypothesis. There have been many questioning the utility of LDL as a predictor or risk factor, but then also whether it even plays a causal role in atherogenic heart disease, despite all of the evidence that it does. And I think a lot of that's born out of various dietary intervention groups that, for one reason or another, with different dietary approaches, we see LDL cholesterol increase. And rather than acknowledging, I guess, it as a potential side effect, or it's questionable, maybe in this context it's okay. And so that's, I think, been a little bit of an alternative hypothesis that's been around for much longer than this Twitter flurry, but like I said, has been reinvigorated, so it seemed worth paying attention to. So that's, this HDL triglyceride profile is essentially asking, among the subset who have HDL and triglyceride levels that look decent, is LDL still harmful or related or associated with higher risk of all-cause mortality? So that's, definitely the background into the drama and the science that I got involved in.
Yeah. So you are very diplomatic and you choose your words carefully, which I appreciate. But at the same time, it's like, let's face it, it's the low carbers, right? The low carb world is pushing this forward, is pushing this concept that when you eat low carb, your HDL goes up, your triglycerides go down, you improve your metabolic health, and your LDL can go up. It doesn't go up in everybody, of course, but in a subset of people, it can go up. So are we protected? Are we low carbers, quote unquote, protected from this dangerous elevated LDL? So you took it upon yourself to say, okay, I have access to this women's health study database, and I'm going to dig into it and figure it out. So tell us a little bit about how you were able to dig into the data and what you found.
Sure. So right off the bat, I want to thank the PIs, the principal investigators of the Women's Health Study, who I reached out to and granted me permission to use the data for this somewhat of a crowdsourcing educational purpose. Doctors Julie Buring and Ayman Lee are fantastic mentors, scientists, and all-around people. So really kudos to them. And then others in the division of preventive medicine, where this data is housed and where my primary appointment is, Dr. Paul Ridker, Dr. Samia Mora, and many others who have derived the data, who have obtained a lot of these biomarkers through funding of their various grants over the years. So the data wouldn't exist without them. So I would love to just, although I did some analyses, it's there because of so many other people. So what I did was we have this cohort that is the Women's Health Study, and they started out many years ago as a small randomized clinical trial that lasted for a couple of years. At the end of the clinical trial, it was converted to this observational, more passive follow-up for incident events over time. So the Women's Health Study started with almost 40,000 middle-aged women, attempting to be somewhat of a snapshot of women across various health professions. So it's admittedly rather homogeneous in terms of socioeconomic and race ethnicity, but the profiles, are fairly comparable to women of that race and income status at that time in the U.S. So, we have BMI is not outrageously in the overweight obesity range. We have a lot of the other metabolic risk factors, maybe slightly healthier than a cross-section if we were to take it today. So that's important to keep in mind. But so among this population of almost 40,000 women at baseline before they were randomized, a large subset of them gave a blood sample. So these blood samples have been banked and stored and assayed for all sorts of different things over the years. So these lipids and other biomarkers, I didn't go out and assay real quick. They're there, they existed, and the data are what I used to conduct this analysis.
So let me interrupt real quick. So the blood tests and the assays were done upon enrollment. Is that what you're saying, or were they followed up with blood tests as well?
The blood samples were taken. Yeah, the blood samples were taken then. I don't know what year the assays for the lipids were conducted. I know they were assayed.
But the time point that they were being measured was when they were enrolled in the study. Okay. That makes sense. Okay. All right, thank you.
Yeah,
Sorry.
And actually we can talk about this more too, because I think it has implications in a little while if you want to come back to this. But this is just a single baseline measure, like a snapshot at one point in time of the women in this trial, and then followed up for 20 plus years for whatever health outcomes and all-cause mortality.
Mm-hmm. Okay.
So we have these 20,000 women who in this subset gave a blood sample and were fasted. So I excluded right off the bat any of the samples that had eaten relatively recently. So we used this 8-hour window before a blood draw to kind of remove any sort of extraneous noise that can come from just having eaten a hamburger or a low carb snack or whatever your favorite meal right before a blood draw might be. We also excluded women who were on lipid lowering therapy. And at the time this trial was enrolling, statins were not up and running yet. So this was in the early 90s, and this wasn't kind of like the go-to treatment. And so that was a very small percentage in the first couple of years of enrollment. We also excluded anyone with a prevalent diagnosis of diabetes. So this serving as some sort of marker of existing metabolic health that could be changing their lifestyle or motivating them in other ways where this kind of single snapshot might be in some way not reflective of their longer term status, right? So this is always a concern. And then women with a history of cancer and cardiovascular disease were also excluded, but they were excluded from entry into the trial anyway, so that didn't kick out really any women. And then, those were the main exclusions. So that left us with just over 19,000 women with this baseline blood sample that had lipids and a bunch of other stuff like their BMI and age, battery questionnaires at baseline and their long-term follow-up.
Got it. And so what you found, so to jump to the conclusion, is that you found LDL elevated LDL in the 5th quartile, which was above, 170, I think, or above 167, did correlate with increased all-cause mortality, regardless of HDL, regardless of triglycerides, and even when you threw in hemoglobin A1C below 5.7, that it all correlated with increased all-cause mortality.
Right. So that subset that we mentioned at the beginning, having HDL above 50, so what we might call a good level of good cholesterol, triglycerides below 150, so triglycerides in a good range. Among that subset of women, LDL was still related to all-cause mortality once we got out into this extreme 5th quintile. So the range of cholesterol in this subset, of course, looks a little bit healthier than the overall women's health study population, right? Once we are limiting to those who have healthier looking triglyceride profiles and higher HDL, we're selecting on a somewhat healthier subset than the overall 19,000. So that's one thing to keep in mind. Right. When we did this kind of first check, I analyzed LDL in everyone just to see, do we even get this expected relationship, or is there something funky going on with the data? So one of those figures I presented, and that's the relationship between higher LDL, dose response, higher all-cause mortality. And then when we look in the subset, the same trend was there that we saw with the overall data, but the power gets a lot thinner. Once you start whittling down your subset, you have fewer events in each of these categories. The number of events that you have is really driving your statistical power. So The relative risks were about on par, as were the absolute risks, so the event rates. But the statistical power got a little bit weaker to really draw any major conclusions about both the like third and fourth quintiles, as well as the trend overall.
Okay.
But
just to
the
clarify,
shape was similar overall to the
okay,
overall cohort.
makes sense. So just to
Yeah.
clarify a couple things, I think you said triglycerides less than 150, but wasn't it less than 100? Or
Yes, I'm sorry, I misspoke.
Okay.
Yeah,
Yeah,
100 for triglycerides and greater
Okay.
than 50 for HDL.
Perfect. All right. Now, so and that's a big thing I wanted to talk about was the power of the study, and also when a study is not sort of meant for this purpose, right? It wasn't a predetermined outcome, and that's usually how you can set a study to be powered for something to be able to detect a difference, because right, you found your conclusions. But there are trials or studies that have shown the opposite. Like there's the Copenhagen men's study by Jefferson, which showed whether your LDL was above 170 or below 170 didn't correlate with cardiovascular outcomes. It was the triglyceride to HDL ratio. And then Castelli from some of the old Framingham data, when HDL was above 65, that LDL from 220 had the same outcomes as 100. But none of these studies were powered to detect that difference. And when you get out to those subsets, you're talking with very few people. So I guess for the layperson, like, how would you say, what is your confidence that either those studies I mentioned or your study really sort of answers the question when it's not meant to answer that question? Does that make sense?
Yeah, no, that's a great question. And I think power is incredibly important in both directions, not to overstate what you see or to toss it away because it's, borderline. I think it basically is this annoying middle ground where you don't really know what to conclude, and you have to look at the whole body of evidence to really make any sense of it. And when you apply for funding to do a really large clinical trial, one of the things you really have to demonstrate is that you have the power to see the result at the end of the day. You don't want to put all this investment in time and energy and resources, do a big trial, and then not really get that many events, right? So you either recruit people who are at high risk, so you'll get a lot of events, or you'll recruit anyone but follow them for much longer. So events like hard clinical endpoints, cardiovascular disease, MI, stroke, and all-cause mortality are extremely difficult to do in the clinical trial setting because of that issue of power. You have to wait a long time or recruit really sick people to be able to accumulate all these events, to be able to see the result that you want. And if you think about it, it all comes down to power is precision. So the more sure you are, the more cases you have in these categories, the more confident you are in the result that you see. Otherwise, there's a lot of noise, and it could, be one way or the other, and not as you're not as certain of that bullseye or that data point. That's basically what power comes down to. So if we're doing a post hoc analysis like this, where we're looking at the data, we don't happen to have that many events. When we look in this third of the women who meet our LDL or HDL and our triglyceride criteria. So right now we're already whittling down, and if we do things like eliminate smokers and have an HbA1c criteria, the subset gets smaller and smaller. We have fewer cases. So there's just a lot less precision and confidence in the results that we come up with. It's this gray area. What do you do with that data? The trend is there, but you have these wide confidence intervals. And I think in some ways that probably just fuels the debate further. But I think, from this epidemiologic perspective, where no one study is conclusive anyway, and you look across a totality of evidence from a variety of different resources, it's consistent, at least in the direction. It's not completely flat. It's not inverse for what we see with LDL and other patient populations or risk strata. And then, you mentioned other studies that had different cut points, 170 versus higher versus lower showed no difference. This population, we didn't even really get that many women above 150. So for their LDL. So, we have maybe a hypothesis hinging more on this extreme end of cholesterol that we're not even really capturing in this population, given that they're relatively healthier if we use LDL as a health metric in terms of the distribution of this LDL being on the lower end to begin with. So even if we had like a handful of women way out there at the higher ends, we'd also have to get cases in those categories to drive the power.
Yeah. I think that's well stated about how to interpret it, that this, one study by itself doesn't answer the question. And I think that's so important, but then incorporating it into all the other data. And then I think it's a question of which data do you choose to incorporate it into, and a lot of sort of personal biases may influence what data you choose, or at least certainly I think that happens for me. I have to be aware of that. But the Twitter response is, as you expect from Twitter responses, like polar opposites, like, oh, this is trash, don't worry about it, or this solves the question, no more debate. And maybe the reality is somewhere in the middle. But the other part about the Twitter reaction is that, which I love, is like the meme of moving the goalposts. Like, okay, now they're going to move the goalposts and say, oh, it wasn't in low carbers. And I had to stop about that because my first reaction was, well, this wasn't in low carbers. But like, is that really moving the goalpost? But then the question of mechanism comes into play. So I'm curious your thoughts on mechanism, meaning mechanism of elevated LDL. Like, if familial hypercholesterolemia is present in 1 in 250 people in the United States, so you could assume that those in this group, there was a subset with elevated LDL who had FH. We have no idea how many. Would that influence it one way or the other? And if your LDL was elevated for some other purpose other than FH, like as a hyperresponder, which we don't know the mechanism of, which we have hypotheses, but we don't know the mechanism of, could that influence the data? And now you're getting into such like a specific question that there's no way this data could address that. So, I mean, is that even important? How do you feel about that?
Yeah, so two things. We do ask about family history of MI. So this is self-report, and about 10 to 15% of the women positively reported a family history. And we adjust on that. So if they report that one of their parents had had an MI, I think even with the condition of prior to the age of 65, then that's something we adjust for. Not necessarily the same thing, of course, as familiar hypercholesterolemia, but it has been a decent surrogate of that. But that said, you mentioned its prevalence in the population generally. Looking in this segment, again, we don't have women, and this is really before the time of statins, with these outrageously uncontrolled LDL levels, which you would presumably be expecting with familiar hypercholesterolemia. So FH may be prevalent in some of these women at this highest category, but I don't see this top quintile as some runaway train of FH women that is overwhelmingly driving the data. But again, that's just my hunch based on the prevalence you would need to have in this set of women of FH to be able to observe that kind of data in the results. And so I think the rarity of it is not compelling enough to explain away that relationship that we see entirely. That said, it could still be a factor. One question about mechanism that I don't know, and this I would love for you to explain to me. If LDL doesn't have a causal role per se and is just like a marker of something other pathologically happening, then it doesn't matter how your LDL gets high, right? Whether it's low carb or sedentary or whatever, right? So we don't know why these women have this elevated LDL in the context of an HDL above 50 and triglycerides less than triglycerides. We don't know why their LDL is slightly elevated. We can see that on average they tend to be, slightly heavier smokers, a little bit less activity. Their BMI is a bit heavier. They have less alcohol intake. There's no striking differences in carbs on average. So what is driving this, spectrum of LDL in these women with decent HDL and low triglycerides? I don't know. There's like basically this distribution of the typical risk factors with some obesity, some smoking, sedentary, etc. So if you have LDL because of any of those reasons versus carbs or low carb diet, I'm curious, what's the mechanism for low carb being a cause of elevated LDL being okay, but all the other risk factors for elevated LDL not?
Yeah, so one of the things that's so important that I wish we had better data and measurements on was this concept of residence time. Like, how long does the LDL stay in circulation before it's removed? Because that can influence things like whether it gets oxidized and whether it gets retained in the vessel wall. If the LDL receptors are removing it efficiently and the residence time is short. And that's one of the hypotheses about low carb hyperresponders, that it's a demand and energy driven process, that, from the VLDLs down to the LDLs, you need more VLDLs to deliver triglycerides. That creates more LDLs. But if they're cleared efficiently, then they're not around long enough, if that makes sense. So you're measuring the pool at any one subset, but the LDLs are constantly being replenished, so they're not sticking around long enough for the particles to embed in the vessel wall. So that's one theory. And we're way out on the theory part of things and don't have the evidence to support that. But that's certainly one of the hypotheses. That makes sense from many standpoints. But can we prove that? No, which is why we need more data and why we need to be cautious, and why I would say we shouldn't completely ignore elevated LDL and say it's perfectly fine, but need to say, okay, let's investigate it and see if we can get better data on that. So.
And in the context of a low carb diet, is it saturated fat? I mean, with all the short-term feeding trials, it seems that certain chain lengths of saturated fat, trans fat, are the drivers of the LDL elevation, and maybe less so other low carb approaches. Is that something that you've seen as well? Or do you think it's just the absence of carbs is what's driving the LDL?
Yeah, that's what's so interesting. And here's where, again, we just have to fall back on clinical experience, because some clinicians in the low carb space will say you switch them from a saturated fat to a monounsaturated fat diet and their LDL comes down. I certainly don't have that same experience with my patients. I know plenty of doctors who don't have that same experience, and individuals who don't have that same experience. So there are people who are following a high monounsaturated, low saturated fat, low carb diet who still see elevated LDL. So the question is why? And there is a concept that as insulin levels go down, maybe LDL receptors are downregulated. But your fuel demands, your demands for triglycerides and VLDLs should be pretty much the same whether you're eating saturated fat or monounsaturated fat, as long as you're in that low carb state burning fat for fuel. Your type of fat shouldn't make a difference there. But I think the data is pretty clear that for the mixed diet general population, saturated fat raises LDL more than other types of fat. So how does that then translate to this kind of energy hypothesis? That I don't know. That I can't speculate on. So yeah, that is an interesting question.
Yeah, and unfortunately, these sort of more experimental hypotheses in the cohort or observational, this epidemiologic setting, are just not really well suited to address. But so I could see well-controlled feeding trials being able to get at some of it, at least for the short term, kind of
right. And measuring liver output of VLDLs, measuring residence time of the LDLs, like if you could do that kind of study. But so this is a fascinating, interesting topic, and I would love to get brains like yours working on this topic more. But I think to bring it back to the study you did from the Women's Health Study, which was a great project for you to do, very interesting, and I think it when interpreted correctly says, look, we do have more reason to be cautious. Just because your HDL is above 50, your LDL is below 100, doesn't across the board mean you are protected from the effects of LDL. But at the same time, it may not answer the question that specific low-carb hyperresponder is looking to answer, and nor should we expect it to, right? We shouldn't expect one study like this to answer a question for everybody. But again, it sets the trend and goes along with other data that is more sort of like generalized and blanket data. So that's my interpretation. Is that sort of how you would agree, or would you put another twist to it?
Yeah, I mean, I think, not as a clinician, which I'm not, but speaking like from the data, I think it's impossible to know if you have a single patient what their individual outcome will be, right? In epidemiology, we deal with probabilities and relative risks and absolute risks. And if you take your risk from 10% chance you're going to have a heart attack in the next 10 years down to 5%, you may have never gotten a heart attack in either scenario. But if you move to situation or diet or intervention A, maybe you would have prevented yours. It's this risk that I think is really difficult to translate from population level research, including trials, where we have, the statin number needed to treat is, 60 to 80 for one prevented MI, but would it have been your MI that it prevented? Who knows, right? But that's what probability is, and it's so difficult to translate to this individual patient level. And I guess to some degree, I don't envy clinicians who have to help patients make these decisions because it seems so hard and daunting. But I commend you for that. Yeah.
Especially when you use that number needed to treat, because depending on your pre-existing risk, it could be high as 250 or it could be as low as 68, right? So where you are on that spectrum.
Exactly.
So it does get confusing.
Yeah. And, I think if there are unique phenotypes in the population, then precision medicine down the road will only work to tease those apart. And if certain therapies are more or less effective than others for populations given these profiles, then, that's totally the direction medicine is moving in. I think one size fits all approaches to care are, for many areas of medicine, going by the wayside. But when you have a patient in front of you who says they eat low carb and they have high LDL, I think right now, I don't know, do we have the tools to say that they're this responder person, or are they general population and probably at risk? And I think that's this precision medicine approach can move towards that refinement. Maybe now is, in my opinion, just seems a little premature, but I also don't see patients. So, again, I'm not having to make these decisions on the individual level, which seems incredibly challenging. But population level wise, it's probability and translating risk that is not an easy task.
Well, thank you for taking the time and the effort. I'm sure it was a lot of effort to do to create this analysis. And I guess last question: Are you gonna take the steps to get this published, or are you gonna leave it as a Twitter study?
Yeah, I don't know. So I've been asked that a lot. I think there's been enough requests to have it published. So I'll at least get it up on bioarchives at some point. And then, with the blessing of my colleagues who technically own this data, move to get it published if I can. Yeah. I think it's
give yourself even more unpaid work to do.
And crowdsourcing feedback on the protocol and getting it all up there. And I really enjoyed the process. I think that's a fun way to do science, and it's kind of a shame that more science isn't done that way. But it's also just a little bit for fun at the same time.
Yeah, we should be commended at how transparent you are throughout the whole process. I think that was important. So thank you.
You're so welcome. I mean, that was a priority from the beginning, for sure.